In the previous lecture, we talked about the alpha blockers, which descend from the class of sympatholytics. Now we will discuss beta blockers. So as the name suggests, beta means that it will act on beta receptors. And the beta receptors, are situated in different organs, and they are divided into 3 subtypes. Now, what is beta receptors? So beta receptors are a type of adrenergic receptors found in the body that bind to and respond to the hormone adrenaline and noradrenaline. Now there are 3 subtypes, as I have already discussed: beta 1 receptors, beta 2 receptors, and beta 3 receptors. Now each of these subtypes, like beta 1, beta 2, beta 3, is located in different tissues and organs, and when activated they show different effects. Now the beta 1 receptors are mainly found in the heart, in the cardiac tissue, but are also present in kidneys and adipose tissues where they metabolize fats. Now the activation of the beta 1 receptor in the heart, it produces, it increases the heart rate and force of contraction. Now note here that the increasing of the heart rate is known as positive chronotropic effect, while increasing the force of contraction is known as the positive ionotropic effect. Now these receptors also, beta 1 receptors also promote the renin release in the kidneys. Now renin, when it is released, it is involved in blood pressure regulation, and it increases the blood pressure through various chain of events, which we will discuss further. Now we will discuss about beta 2 receptors. So the beta 2 receptors are present in the smooth muscles of the bronchi and lungs, and blood vessels of the skeletal muscles, I would specify here, and smooth muscles of the bladder and uterus. You can say that, and uterus. I'm not saying about the bladder is uterus and uterus. And they're also present in the liver, where they show number of actions. Now in the lungs, they cause relaxation of the bronchial smooth muscles, and in return causes bronchodilation and improved airflow in the lungs. While in the blood vessels of the skeletal muscles, they also cause vasodilation and improved blood flow towards the skeletal muscles. Because beta receptors are adrenergic receptors, so we are talking about sympathetic effects here, like stimulating these receptors causes sympathetic effects. Now in the bladder, they cause relaxation of the sphincter, while in the liver, they promote glycogenolysis, like conversion of the glycogen to glucose, because the body needs a tremendous amount of energy in that particular state. Now beta 3 receptors are mainly located in the adipose tissues, which is the fat tissue, and activation of the beta 3 receptors in fat cells promote lipolysis, like breakdown of the stored fat, and thermogenesis, which is the production of the heat. Now in that particular state, like in the sympathetic state, we need glucose from lipids, and we also need heat to do complex tasks. Now these receptors basically play a role in regulating energy metabolism and body temperature, beta 3 receptors. Now they are also present in the bladder, where they promote smooth muscle relaxation of the sphincter. Next we are going to move towards is classifying the beta receptor antagonist. Now note here, we talked about the beta receptor stimulation in the previous slide. Now we will be talking about beta receptor antagonists, like they block the beta receptors. And when we block beta receptors, so all of those events that are happening in these tissues and organs will be changing its direction. So the beta adrenergic receptor antagonists can be divided into 3 generations, like first generation, which is non-selective, and then second generation beta 1 selective, and then third generation, which is also vasodilatory, and it is also can be classified into 2 more types, like non-selective and beta 1 selective. So first we will understand what this generation means. So basically these all beta blockers are divided based on their properties, selectivity, and clinical uses. Non-selective meaning that they act on beta 1 and beta 2 receptors like nadolol, oxpranolol, penbotalol, pindolol, propranolol, sotalol, and timolol. Then second generation beta 1 selective meaning they are basically the cardioselective beta blockers, and they include acebutolol, atenolol, bisoprolol, ismolol, and metoprolol. We will discuss it further in detail. Third generation, which I already discussed, vasodilatory, like it produces vasodilation, and due to this specific effect they are used for multiple symptoms. And we have non-selective, which act on beta 1 and beta 2 both, and beta 1 selective, which is betaxolol, nebivolol. Non-selective is calciolol, carbidiolol, and labetalol. Now let's understand each of the generation in detail. Now we will discuss about first generation non-selective beta blockers. Now note here, non-selective meaning that these drugs would act on beta 1 as well as the beta 2 receptors. Now beta 1 receptor, in the beta 1, let's just discuss beta 1 first. Now beta 1 is located in the heart, and it promotes the heart rate increasing and contractility increasing and blood pressure increasing. Why? Because it promotes positive ionotropic, because it is adrenergic receptor, right? So it will increase the heart rate, contractility, and BP. But why you need blocking of it in the classical angina? Now in the classical angina, beta 1 blockers are used, non-selective beta blockers. Now they act on beta 1 and they decrease the heart rate, contractility, and blood pressure in return. Now first let's discuss what is classical angina. So classical angina is basically a stable angina or effort angina, which causes chest pain and discomfort, and it occurs when there is temporary decrease in the blood flow to the heart muscle. Now heart muscle is known as myocardium. Now it occurs, note here, when there is temporary decrease in the myocardial oxygen demand. Now it is triggered by physical exertion or emotional stress, and is relieved with the rest or taking beta 1 non-selective beta blockers, which act on beta 1 obviously. Now beta 1 blockers are given in the classical angina to decrease myocardial oxygen demand. When the heart rate, contractility, and blood pressure is reduced, myocardial oxygen demand is reduced, and decreasing the myocardial oxygen demand eases out the symptoms of the classical angina. But these non-selective beta blockers are contraindicated in variant angina. Now what is variant angina first? Now variant angina, also known as Prinzmetal's angina or vasoplastic angina, is a type of angina that occurs due to coronary artery spasm, rather than the typical narrowing or blockage of the arteries seen in classical angina. So here coronary vasospasm is happening, rather the typical narrowing or blockage of the arteries seen in the classical angina. Now, why we don't give non-selective beta blockers in variant angina? Because they also act on the beta 2, and blocking the beta 2 will cause coronary vasoconstriction. Why? We already discussed beta 2 is present in the blood vessels, and they promote vasodilation by relaxing the smooth muscle. Now by blocking the beta 2, we will have coronary vasoconstriction. Now already the heart is requiring more oxygen. Myocardial oxygen demand is high, and we are giving it coronary vasoconstriction, which in turn promote vasospasm. So vasospasm is a dangerous state in the variant angina. It is basically variant angina. So we don't give non-selective beta blocker in variant angina, but we can give it in the classical angina. I repeat, beta 1 are present in the heart. They reduce the heart rate. Blocking them would reduce the heart rate, contractility, and BP, which in turn eases out the symptoms of the classical angina. But in the variant angina, because vasospasm is happening, giving the non-selective beta blocker would block the beta 2, which in turn will promote coronary vasoconstriction. And for this reason, non-selective beta blockers are contraindicated in the variant angina. Next, we move on towards beta 2 effect on the lungs. Now, I already told you that beta 2 are also present in the lungs. Now, in the lungs, they promote bronchodilation. Stimulating the beta 2 receptor would promote bronchodilation. But beta blocker, giving the non-selective beta blocker, you block the beta 2, it causes bronchoconstriction. Now, bronchoconstriction is the narrowing of the passageway of the air, so it is contraindicated in the bronchial asthma patient. Now, a very important point, in the bronchial asthma patient, we don't give non-selective beta blockers because they block beta 2 and bronchoconstriction happens and the symptom will worsen. Next we have is, now blocking the beta 2 would also cause dyslipidemia. Now what is dyslipidemia? Dyslipidemia refers to the abnormal levels of lipids such as cholesterol and triglycerides in the blood. Now, lipids are essential components of the body and they play vital roles including energy storage, insulation, and the formation of the cell membranes. Now, blocking the beta 2 would increase the low-density lipoproteins, which are the bad cholesterol, and decrease the high-density lipoprotein, which is good cholesterol. Now, why? Because beta 2, I already discussed in first few slides that beta 2 are also present in the liver, and stimulating them would cause gluconeogenesis, which is the synthesis of glucose, and glycogenolysis, which is the breakdown of the glycogen. Now, the reason B2 is promoting gluconeogenesis and glucogenolysis is because the sympathetic effect, like the body needs energy. Now, blocking them would cause dyslipidemia and would, disrupt the lipid profile. Now, in the patients taking insulin and other hypoglycemic agents, the chances of reversal of hypoglycemia will be decreased because glucose metabolism is also disrupted, gluconeogenesis and glycogenolysis. And so lipid metabolism is disrupted due to beta blockers blockage, and the glucose metabolism is also decreased. Now, due to this reason, the diabetic patients taking non-selective beta blockers, they have the risk of the decreased chances of reversal of hypoglycemia. So the hypoglycemia propagates and, it causes symptoms, which I have discussed it in further few slides. So next we have is beta 2 blockers also decrease the aqueous humor production. Like beta 2 stimulation increases the aqueous humor production, but beta 2 blocking the beta 2 receptors would decrease the aqueous humor production. Now, this aqueous humor production reduction is beneficial in the treatment of the glaucoma when the intraocular pressure is subsequently increased and we need to decrease it somehow. Now, what is aqueous humor? Now, aqueous humor is basically a clear watery fluid that fills the anterior chamber of the eye, which is the space between the cornea, the frontal part of the eye, and the lens. Now, it is one of the several fluids present in the eye and plays a crucial role in maintaining the health and function of various, eye structures. Now, in the glaucoma, it is increased. Now, beta 2 blockers are given to decrease it. I repeat, first generation non-selective beta blockers, beta 2 receptors are present in the lungs and they cause bronchodilation. Now, blocking them would cause bronchoconstriction. So, for this reason, they are contraindicated in the bronchial asthma patients. Now, beta 2 receptors also increase the gluconeogenesis and glycogenolysis. Now, blocking them would cause the carbohydrate metabolism problem and the lipid metabolism problem. Now, the lipid metabolism problem is dyslipidemia, and the carbohydrate metabolism problem is the decreased chances of the reversal of the hypoglycemia in the diabetic patients or the patients taking oral hypoglycemic agents. Next, beta 2 blocking the beta 2 would also decrease the aqueous humor production, which is beneficial in the treatment of glaucoma. Next, we will move on towards limitations of the first generation non-selective beta blockers. Now, first we have beta 2. Now, beta 2 receptors already discussed present in skeletal muscles, vessels, and they cause vasodilatation, which is a sympathetic effect. Now, beta 2 stimulation causes vasodilatation. If you block them by non-selective beta blockers, they cause vasoconstriction in the skeletal muscles. Now, when the vasoconstriction happens in the skeletal muscles, oxygen demand is increased, like oxygen supply is decreased to the muscle. Now, in exercise, in a specific situation like in exercise, skeletal muscles need immense oxygen while the patient is taking non-selective beta blockers. So the vasoconstriction is happening. The person cannot exercise. Now, it is the first limitation of the non-selective beta blocker. Second limitation is in the diabetes mellitus patient. Now, diabetes mellitus patient, if a diabetes mellitus patient is on insulin and oral hypoglycemic agents. Now, what insulin and oral hypoglycemic agents sometimes do is they cause hypoglycemia, which is the decrease in the blood glucose level. Now, hypoglycemia symptoms include tachycardia, sweating, and tremors in general cases, like it is the sympathetic stimulation. Now, if non-treated, hypoglycemia non-treated, it can land up in coma. But the patient doesn't go in the coma usually. Why? Because the patient is exhibiting the symptoms of tachycardia, sweating, and tremors, and the doctors know, and they, give it the glucose. So tachycardia, sweating, and tremors diminishes, and the patient is back to the normal state. But here is the catch. Now, if a diabetes mellitus patient is taking beta-2 blockers, like non-selective beta blockers which act on the beta-2, now what beta-2 blockers do is they decrease the sympathetic stimulation or inhibit it. When they inhibit the sympathetic stimulation, they are basically masking the effects of hypoglycemia. Tachycardia, there is no tachycardia, no tremor is happening, but only the sweating is happening. Why only sweating is happening? Because sweating is controlled by sympathetic cholinergic stimulation and not only the sympathetic stimulation. So only sweating is happening, but the patient doesn't, exhibits the normal symptoms, which is tachycardia, sweating, and tremors in hypoglycemia. So patient might not know that he's in hypoglycemia, or the doctor might not know, and the hypoglycemia may propagates into coma. But so beta-2 I repeat, let's suppose a patient of diabetes mellitus is taking beta-2 blockers. Now, if somehow he lands up into the hypoglycemia state, and he's showing tachycardia, sweating, and tremors because of the beta-2 blockers, tachycardia and tremor doesn't happen because it blocks the sympathetic stimulation. Now, if tachycardia and tremors is not happening, the patient might land up in the coma because he will not take the glucose. Sweating, however, proceeds because sweating is controlled by sympathetic cholinergic stimulation and not only the sympathetic stimulation. So it is contraindicated. Beta-2 blocker, non-selective beta blockers are contraindicated in diabetes mellitus patients. It is the second limitation because the patient might end up in coma due to decreased symptoms of hypoglycemia, which is tachycardia, sweating, and tremors. You understand? Third is Raynaud's syndrome. Now, the Raynaud's syndrome or the Raynaud's disease is a condition that affects the blood vessels, primarily in the fingers and toes. Now, it is characterized by episodes of reduced blood flow to the extremities. You can see the hand is pale in some part, and it is reddish in some part, meaning the blood flow is normal in this part, while in this part, the blood flow is decreased. Now, it causes color changes in the affected areas and associated symptoms. Now, note here that, now as you know, beta-2 stimulation causes vasodilatation and its blockage causes vasoconstriction. Now, due to this vasoconstriction, the Raynaud's syndrome can be worsened. Now, for this reason, in the patients who are affected with the Raynaud's syndrome, non-selective beta blockers are contraindicated in such kind of patients. Next we have is second generation selective beta-1 blockers. Now, they are also called cardioselective beta blockers. Now, the selective beta-1 blockers, as the name suggests, they act on beta-1 receptor present in the heart. So they are cardioselective beta blockers. We can remember the drugs included in selective beta-1 blockers by a mnemonic called nu beta blockers acting exclusively at myocardium. Now, nu stated for nebivolol, beta for betaxolol, blockers for bisoprolol, A for acebutolol, exclusively for esmolol, at for atenolol, myo for metoprolol, and cardium for celiprolol. Now, the beta-1 blockers basically have some advantages over non-selective beta blockers. They are safe in diabetes. Now, beta-2 receptor blockade can cause decreased chances of reversal in hypoglycemia. Now, the advantage of selective beta-1 blocker is they only act on beta-1 and they don't cause hypoglycemia-related symptoms to mask. Next is safe in peripheral vascular disease. You know that peripheral vascular disease can occur due to vasospasm of the vessel. Now, if you give beta-2 receptor blocker, then a vasospasm happens because of vasoconstriction. So we don't give non-selective beta blockers, we give only selective beta-1 blocker. They don't cause vasospasm in peripheral vascular disease. So they are safe in peripheral vascular disease. Next is less likely to impair exercise capacity. Now, you know that because of the vasoconstriction in the skeletal muscles, the oxygen supply is decreased, which can impair exercise capacity. So in patients where we have a risk of impaired exercise capacity, we give only selective beta-1 blockers and not non-selective beta blockers. Less risk of hyperglycemia. Already stated that it decreases beta-2 receptor blockade and decreases the reversal of the hypoglycemia. So we give only selective beta-1 blockers, so they are safe. A less risk of dyslipidemia. Beta-2 again can cause increased level of low density lipopolysaccharides and decreases the high density lipopolysaccharides. So dyslipidemia occurs. So we only give selective beta-1 blockers. They have less risk of dyslipidemia because they don't act on beta-2 receptors. Next we have is limitations of second generation selective beta-1 blockers. Now, the selective beta-1 blockers can cause bradycardia. Now, this is their limitation. Why? Because beta-1 receptors are present in the heart, and by blocking them, you reduce the heart ionotropic and chronotropic effect, and the heart rate decreases, bradycardia happens. But there is some good news. There are some selective beta-1 drugs that cannot cause bradycardia because they have some partial agonistic activity on beta-1 receptor. Now, I repeat, selective beta-1 blockers can cause bradycardia, but there are some selective beta-1 blockers who have some partial agonistic activity and they don't cause bradycardia. Smiley face, they don't cause bradycardia. And these drugs are celiprolol, oxpranolol, pindolol, alpranolol, and acebutolol. Next is the second limitation of second generation selective beta-1 blockers is they can cause rebound hypertension. Rebound on sudden withdrawal, like if you suddenly stop the drug, rebound hypertension can occur. So we always have to reduce the dose enough that rebound hypertension don't occur. Next is third generation beta blockers. So here we have an additional vasodilator property which causes vasodilatation. It can be due to various ways and effects. We will discuss each of them. Now, first is alpha blockers, in which the most important drugs are included labetalol and carvedilol. What they do is they block the alpha receptors also, and they cause vasodilatation. Medroxalol and bucindolol is also included. Next is release of nitric oxide. Like you already know in the previous slides, the release of nitric oxide causes increase in the cyclic AMP and cause vasodilatation, in which the drugs are included are nebivolol, potassium channel opener. Some drugs like telisolol opens the potassium channels and causes vasodilatation. Next is calcium channel openers. Carvedilol, bitoxolol, and biventolol causes opening of calcium channels, and through this they cause vasodilatation. Beta-2 agonistic, beta-2 blockade causes vasoconstriction, and beta-2 agonistic activity causes vasodilatation. So some drugs like celiprolol, cartiolol, and bopindolol may cause additional vasodilator property and are included in third generation beta blockers. They also have some side effects like fatigue and dizziness may be reported, bradycardia, which is slow heart rate, hypertension, which is decreased blood pressure, and sexual dysfunction, which is the penis doesn't erect that much and causes sexual dysfunction. So this was all about today. Keep following sqadia.com for more such videos in the future.
Ever felt overwhelmed by the traditional way of learning medicine? Enter the future of education with digital learning. Whether you're refining your knowledge of biochemistry or immersing in cell biology, it's all there. Understanding complex medical subjects has never been easier or more efficient with engaging, interactive content. Welcome to the new age of medical education. Learn anywhere, anytime, at your pace. Powering your medical journey. sqadia.com